بسم الله الرحمن الرحيم. أهلا وسهلا بالجميع. I hope you can see my screen and you can hear me. You can yes, you can see. Okay. Okay. And you can unmute yourself because it is very interactive session. I can see Professor Shireen Al-Hariri with us, one of the very eminent examiner, and he's very, very welcome. أهلا وسهلا Professor Shireen. Okay. So, I think you all have the MRCS exam either in February or April. Is there anyone booking in any other time than these two? Dr. Amira, Dr. Karim?
أنا أبريل إن شاء الله.
April, okay. And Dr. Karim? Maybe he can't speak. Okay. I will some sort of OSCE training to candidates, and that is why I have created this program. And if anyone eager to have this exercise, and then we can discuss and see how it goes. This is a program about communication skills. Start, and we probably need a volunteer, and I will see if you can open the voice. This is right iliac fossa pain, possible appendicitis, simple, straightforward history station. When you enter the station, this is patient called Sarah Jenkins, right iliac fossa pain, possible appendicitis. This is very common communication skills. Number one, my advice to you all, whenever you go to a history taking station, please use pen and paper to write down. Write down in clear English, because at the end of your station, we look at this paper, what did you write down? Number two, you have 6 minutes. So please, 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 focus in your history. Don't go in too much detail, for example, about smoking. How much did you smoke? For how long? How many packets a day? Did you suffer from smoking? Did it cause you any problem? So please focus your history. So here is the station, started after 1 minute. Good morning, Mrs. Jenkins. How can I help you today?
It hurts really badly. My tummy, it's killing me. Please, can't you give me something for the pain?
This is very important. Whenever I stopped at the station, whenever we let the patient tell you, I am in pain, do you know what is this for, Dr. Amira?
Yes, doctor.
Do you know what it is, what you should do if the patient tell you, I am in severe pain?
I will prefer for her to give her painkiller.
Yes, painkiller. Offer analgesia immediately. Yes. And this is very important, to offer analgesia right away. Secondly, I put here in this station the item that you need to cover. So let us resume. I'm very sorry to hear your pain, Mrs. Jenkins. Shall I give you analgesia right now? Shall I give you analgesia right now, Mrs. Jenkins?
It hurts so bad. I need something for the pain right now. Yes, please. Anything to make it stop.
Okay. Can I check your full detail, your name and date of birth? Is that okay with you?
Just please give me something for the pain.
Okay, I will tell the nurse to give you analgesia by injection right now. Is that okay with you?
Yes, just please give.
Okay, How long ago did this pain starts?
This morning, in the middle, now it's on the right. It's so bad.
From a score of 0 to 10, how much do you score your pain?
I don't know, maybe an 8? It's really constant. Can I have
Okay.
that pain?
Yes. Do you have nausea or vomiting, Sarah?
Yeah, I feel sick. I threw up once this morning.
Okay. Can I call you Sarah? Is that okay with you?
Sure, but the pain. Can I get something for it soon?
Yes, I will get you another injection right now after we finish the history. Have you missed any menstrual period?
No, I had my period 2 weeks ago.
So it's unlikely that you are pregnant. Do you take any contraception?
No, I'm not pregnant.
Okay. Are you allergic to any drugs?
No allergies.
Did you have any previous surgery or previous operation?
No surgeries before.
Okay. I will stop here and ask you, Dr. Karim or Dr. Anas, what do you like to ask her within the 6 minutes? I stopped the station, so don't worry. If you have this station in your MRCS exam, Dr. Karim, Dr. Anas, you can unmute yourself, speak, or Dr. Amira, and say, what do you want to ask her something else?
بس medical history for previous admission with the
Yeah.
same attack.
Yes.
Any previous surgical history.
Yeah, she said she didn't have any previous operation before.
Um,
What about drinking alcohol? Can she have
Yes,
pancreatitis?
yes, you can ask for drinking alcohol and the smoking.
Yeah, very good, Dr. Amira. Okay, let us resume. Uh, I will ask you a few questions about your social history. Do you smoke or take alcohol? Do you smoke or take alcohol? Do you smoke, Sarah, or take alcohol? Do you smoke or take alcohol, Sarah? Do you live alone or you live with someone else? Okay. Sometimes, again, when there is too much traffic on the station, you get this kind of program stops in the middle. But
And
anyway,
she answer you in the chart, doctor.
yeah, she answered before. Okay. So I will stop the station here and I will see the golden standard history. This is query acute appendicitis. I should ask about Socrates for pain sequence, pain migration. I didn't get into much of detail except the pain score. Associated symptom, I should ask about loss of appetite, nausea, vomiting. She said she had vomited. Gynecological history is very important. Please don't miss because of the possibility of ectopic. I did not have a chance of urinary symptom, which is important. Past menstrual history and social history, as does she lives alone or not. Then you can get an assessment of my performance, and here you still get more advice about this station. We have Dr. Jamal with us, welcome, and Dr. Ahmed, welcome. You can open your camera, you close your camera as you want. So I did fail in this station, 6 out of 20, but let us see the analysis of my communication. I will enlarge it here. Severely compromised. The candidate used mixed broken English. My English was not very clear, and this is important for you when you go to the station. A lot of candidates get Arabic words. يعني, بس, أقصد. And this lower your mark. Sentence were grammatically incorrect. Again, I advise candidate to use short sentence, not a long sentence because you get mistakes. So, where is the pain? How much do you score the pain? Did it radiate anywhere else? So you must get used to short sentences. Okay? Data gathering, superficial, because I was missing asking about pregnancy, past surgery. Dr. Amira mentioned past surgery. I didn't go into Socrates in full detail about the full detail. The structure and rapport, it did show that I did not have a system. So always, please, when you go to the exam, taking history, start by confirming patient ID, name and date of birth. Present the complaint, history of the present complaint, other system review, past medical history, social history, and then you give a summary. And you also can mention ICE, what you are concerned about, if he did not tell you what I'm concerned about. Okay? And the clinical judgment correctly identifies the need for analgesia. Whenever she said she is in pain, I offer analgesia. This was a good point. I think this is the 6th mark. I took it for offering analgesia. Okay? Urinary symptom is a red flag. I didn't ask about. Bowel habits, diarrhea, constipation, didn't ask about. Vaginal discharge, temperature or fever. These are called red flags, and you must ask about them. Overall feedback, this is obviously bad performance. And what I have done well, I address the patient immediately requesting pain relief. So this, whenever patient tell you he is in pain, always offer analgesia. And correctly ruled out pregnancy. I've told her is this possibility of pregnancy. This was good. And checked for allergy. Area of improvement. How can I improve? Language. I should improve my English. I should complete the history and lack of professional structure. And these are the points. Must practice history taking. And this is why this program is designed to practice a lot on history taking and go to the dashboard. Any comment from any of the attendee? You can unmute and you can speak. Anyone have a comment? Doesn't seem to have a comment. It's okay. I hope it is clear. So let us take, here is the station. Start another scenario. Here is lump in the groin, strangulated hernia. Again, common station. Fell down and hurt his hip. That is fracture neck femur. Anyone ready to take fracture neck femur? The main aim of this exercise, number 1, to get you passing the stress of the exam. Number 2, to get used to OSCE station. So what I shall do, I should concentrate in the exam, what I should say over 6 minutes. So anyone want to take this station?
Yes, Dr. Muhammad, I can take it.
You can take it. Very good. Your name is Dr.
Muhammad, right?
Dr. Muhammad. Okay, very good. Okay. Now what I will do, I will start the station and you can tell me what you want to say and I will say it to the actor.
Okay.
Is that okay? Very good.
Yes.
We'll start the station. You get 1 minute. You can see the score is 1 minute. it is Elsie Tanner, neck femur with mild delirium. So be very careful. This is probably an old lady falling down, and be careful with delirium plus possibility of neck femur. Okay, are you ready, Dr. Muhammad?
Yes, I am ready.
Okay, very good. Start the station. And
Okay.
what question do you like to start with?
I will introduce myself to the patient
Excellent, very good.
and my job, and I will explain here what I'm going to do now and take a
Okay,
consent regarding it.
you
And I
missed
will,
one point. You missed one point. Number one, you need to check patient identity.
okay,
Can I confirm your name and age, please? And this is
yes,
before you start.
okay, yes,
Okay.
right.
Okay, so let us do that. Good morning. I am one of the exam doctor for today. Can you confirm your name and age, please?
It's Elsie Tanner, and I'm 78. Where's Tibbles? I can't see him anywhere.
Do you know what is Tibbles, Dr. Muhammad?
Tables,
It mentioned where is Tibbles.
I don't know what is tables.
Yes, Tibbles probably her cat or her dog.
Ah,
And this is a nickname because she is confused. Remember this? She is confused. So there are two things that you can do to assess their delirium state. Do you know any scheme to assess that?
yes, I can ask here about. Uh, could you know where we are right now?
Very good. What is the name of this?
What is the name of this? What
Of
is the
this
name of
scheme?
this? Yes.
Okay.
Could-
So number one, you see here, this is the items that you should cover within 60 minutes. Patient ID is a check because you already covered it, but you need to confirm present to complain, history of the present illness, and you should notice that she is confused. So you want to say to her now, what is your complaint? Are you in any pain? Shall I give you analgesia, or what do you want to say, Dr. Muhammad?
Yes. What exactly your problem today?
Oh,
Can you
very
tell
good.
me?
Okay, we'll do that. I'm very sorry to hear that, Mrs. Tanner. What is the problem today? What is the problem today?
I tripped over the cat, I think. My left hip is throbbing. I just want to find Tibbles and go back to my own kitchen. Have you seen Tibbles?
What would you say, Dr. Muhammad?
I will show sorry. I'm very sorry to hear that. Do you need any painkiller right now? I
Very
can
good.
arrange you.
I'm very sorry to hear that. Do you want any painkiller now, Mrs. Tanner?
Oh, my hip hurts awful bad. Did you?
Do you want any painkiller,
Did?
Mrs. Tanner?
Oh, yes, please, if you can help. My hip just kills. But did you look for my cat? Tibbles, he's right around here somewhere.
Okay. So now you have around 2-3 minutes is gone by this introduction, and she is confused. So what you are going to do, Dr.
Okay, I will.
Muhammad?
Yes, I will. I will arrange those nerves to offer you painkiller right now.
Painkiller right now?
And
Good.
regarding tables, I will see and check if it here. I will update you. I will let you know. I can help you regarding
Okay.
this.
Okay.
Definitely.
Yeah. Oh, so you replied nicely. I don't know where stable is. That is a nice reply because in this station you get a surgeon and you get a lay examiner who is not a doctor at all, but just an expert in how you speak to patient. So You mentioned that, but you need to focus on the history. So you need to know from her when it happened, this fracture, and she said she is in pain on the right hip. Then you need to review other system, and you need to go to social history. If she lives alone or not, does she have a family? And again, you ask about drug history, social history, all the normal questions. Okay?
Yes. Okay.
What is the red flag in these conditions? What is the red flag symptom? Someone
Uh,
old age.
red flag symptoms in is
Like
regarding pain
pulmonary
itself.
emboli. Pulmonary
Yes.
emboli. Okay,
Yes.
she's an old age. She might be bedridden, and this is fracture hip. She can have an emboli. So asking about respiratory symptom
Yes.
is important. Okay,
Yes.
so your reply will be what?
I will ask about pain itself. I will analyze the pain. What is the
Analyze the
site
pain, which
exactly
is
from where?
Socrates.
Yes.
Okay, so you start number one by what? Pain severity.
Where exactly you feel the pain?
Okay, where is the, exactly is the pain, and how much do you score this pain from score 0 to 10?
Oh, my left hip hurts terribly.
And the pain
Yes,
score? Yes.
it's quite bad. I can't put any weight on it. I'd say it's maybe a 9? Where's Tibbles? I haven't seen him since I fell.
I'm sorry, I don't know where Stibble is, but can I ask you a few questions? Do you live alone?
Yes, I do. But my carers come in a couple times a day. They're usually very helpful. Do you think they might have seen Tibbles?
Okay. So you see the scenario, so always go to Tibble because she's confused and her carer comes to her. You know what is her carer, Dr. Muhammad?
Yes. Yes. One of members that help
Yes,
her in
social service. Yes, social
social
service.
service, like
When
social
you are,
services.
yes, yes. When you are in United Kingdom and you're old, you cannot manage on your own. Social service send some people to you called the carer. Okay, and then
Okay.
we review other system, mainly respiratory for PE. Do you have any problem with breathing or a chest pain or any pain anywhere else other than your left hip? Do you have any chest symptoms?
My hip hurts real bad. Just this one place. Have you seen my cat, Tibbles? He should be around somewhere. I just want to go back to my kitchen.
Okay. Okay. So how do you ask about confusion, Dr. Muhammad? How do you ask about confusion? You ask her a few
Yes.
questions. There are usually 7 questions and you get a score. You know what is this called?
Yes. I what's called ATMS to assess the
Yes.
confusion in rapid
Yes.
question. I will ask about the year and months and what season and
Yes.
ask about time, what's year
Yes.
and what's months. Ask about
Yes.
place. Ask about which country, which town we are in. What about street? Do you know the name? Which is spelled in name, and
Very
if you
good.
remember the floor. And ask about subtraction if you can doing some
Subtract
subtraction.
backward. Very
Yes,
good.
backward. Give here some words to spell it or to remember it, and I will ask later about these words. Ask about
Yes.
identification of objects. What is this like pen? What's my job? And what's this about nurse like?
Very good.
Uh, yes, all this to assess the
Yes.
confusion
Yes. Very
in
good.
rapid questions.
Very good. So let us say we'll finish the station here. Okay. Stop station. Let us look at the golden standard of this case. Neck femur, gold standard history. Number one, fall mechanism. How did you fall down? This is important. Okay. because she will tell you either I got chest pain, then I fall down, or I got syncope and I fall down. She might have a stroke. So the way she fall down is important. Injury, immediate instability of weight. She cannot weight bear after she falling down. This indicate fracture femur. Past medical history, osteoporosis, any previous fracture, steroids or malignancy because she's an old age, 75. And AMTS, you mentioned cognition, measure cognition function. Very good, Dr. Muhammad. Very good. So you will do AMTS. How can the actor tell you that I am confused? It will tell you that by where is my cat? What happened to my cat? And usually we give the actor instruction to ask one question correct, one question wrong. Where you are, I am at home. He should be in the hospital. What is this month? He will tell you April. Okay? So it's very good. You will do MTS score. Social history, pre-morbid morbidities like she is stuck at home and she cannot go upstairs. All this is important. So let us see the analysis of their performance. But your performance was very good. I did not complete the station. We did not ask about drug history. Whenever I stop the station and I speak, because the mic is working, it confuses the system a little bit. But when one is doing it, then it is not a problem. Here is the examiner is marking your performance. Will give us assessment about how we have done. Here is assessment. Again, bad score, but this is the main thing. The main thing is communication. I think we did communicate well, Dr. Muhammad. Data gathering, we did not much ask about data because very confused. We did not ask about osteoporosis, drug history, anticoagulation. We didn't do that. Clinical judgment, you correctly identified the need for analgesia. This one we got the mark. And attempt to rule cardiac cause, we should ask about breathing, chest pain, as we mentioned, possibility of MRI, elderly frail assessing cognition by AMTS or 4AT, but usually take AMTS as the score to use. Structure of your consultation. And here are the red flag. Failure to assess delirium is a red flag. You must say this is confuse the patient. So you will ask, if you have a patient confused, what difference management you will do, Dr. Muhammad?
If confused, I need to assess the cause of this confusion. If it's like in old age, or if it metabolic, like a metabolic disorder or some trauma or something like this, I will do examination first, then investigation for the patient and assess exact the cause and treat the cause first for confusion.
What investigation? You mentioned electrolyte. What else?
Yes, electrolyte and measure blood glucose level is important. And measure temperature of the patient. Hypothermia cause confusion. Measure APG. Measure doing scan like CT scan for head.
CT scan for the brain. Yes, that's true. And sometimes you can call psychiatrist.
Yes.
The on-call psychiatrist because patient has delirium. Okay. Missed anticoagulation status, drug history. We did not ask about that. Did not assess head injury, but this is not your fault, Dr. Muhammad. It's because I just took a quick history to have the flavor of the whole station. We did not assess fallen head injury or loss of consciousness. Overall feedback, poor performance, failed to address complexity in geriatric trauma patients. Okay, fine. So this is one of the important station that can come in the exam. Okay, and we can go to another station. and we can have little bit of
دكتور عندي سؤال
exercise. Yes.
الحين الهيستوري femur fracture
أيوة.
by itself will take time more than if I will do also a mini mental assessment score.
Yes, it will take time, but you should do it quickly within the 6 minutes. So you must get used for you to have, let us say, 2 minutes AMTS, and the rest of the 4 minutes is very quickly social history, drug history, review other system. The system of the exam is focus the history. I know that you can have the whole 6 minutes in AMTS. I know that. But you must
Yes.
get used to a quick 7 questions within 2 minutes with the reply.
Okay.
Okay? And this is very important time constraint of the exam. Okay? This is very important. Okay. Now, let us...
I have one question, please,
Yeah,
doctor.
please.
Should we start with AMTS or the neck femur injury in taking history?
What is neck femur? What do you mean neck femur injury?
I mean to take history from the
History
patient
of the
about
neck
his
femur?
pain. Yeah, about the pain or first or AMT score first.
Well, that's a good question. That's a good question. Number one, you start asking about the presenting complaint, which is pain on the left hip, and then analyzing the pain, which is history of the present illness. But after that, because you can see the patient in the scenario, tell you, where is my cat? Where is my cat? Where is my cat? And this is for you to test the candidate, you should assess mental state. You should tell me I'm assessing the mental state. Then, quickly over 2 minutes, we know that she has delirium, and then I will go to complete the station with the rest of the 4 minutes. So, what I mean, introduction, neck femur, the actor keep asking, where is my cat? Where is my cat? Where is my cat? After the history of the present illness, I will do AMTS.
Okay, doctor. Thank you.
And this needs a training. Needs a training. I remember candidate took the whole 6 minutes with AMTS. Okay? So you must know to do AMTS score within 2 minutes. And 4 minutes very quickly to cover focused history.
Okay, doctor. Thank you.
Okay? Very good. Very good. Any other questions? Okay. Here is ATLS trainer. Yeah. Any questions?
Yeah, I'm really sorry, but sir, my exam is in UK, and my English, I'm Arabian native, so it's not that well. So I thought if I think like if I go on this system AMTS and then I will go for the history, I will never finish. I will never finish.
Yes, this is a good question. A lot of people told me that I could never take a history over 6 minutes. And I always reply to them, the exam is 6 minutes is not going to change. You have to change to be trained within 6 minutes to cover important points. You can do that either with your colleague or with artificial intelligence. And this, it will teach you how within 6 minutes you cover the subject. So this is very important. I remember candidate told me I could never do abdominal examination within 6 minutes. And I told him, show me how do you do abdominal examination. And he took 2 minutes doing inspection. I told him inspection take 10 seconds. What more do you want from an inspection? So this is very important question, comes very frequent, that there is no much time. No, we test your ability to do the allocated task in allocated time.
Sir, I'm really sorry, but I have another question. Like,
Yes.
if the patient is really confused and her AMTS was less than 6, how she could give a history? How she's reliable to give a
No,
history?
she still, yes, she still can give you a history. You remember when I asked her, do you live alone? Yes, I live alone, and my carer come to me once or twice a day. There are multiple level of delirium. If she is delirium with very bad score, then you cannot take a history. But this station does not come in the exam.
Okay.
In the exam, I want to test your ability to take a history. So I always bring an actor to show little bit of delirium, but not much. So you are able to take a history.
Thank you.
You're welcome. You're welcome. Any other question of the other candidates? Okay. Now, you know, there are two courses very important for you to read the summary before going to the exam, which is ATLS course, Advanced Trauma Life Support, and the CRISP course. And these two courses can come in the exam. So someone will tell me how it can come in the exam. Well, it can come if you have a patient with pulmonary emboli and he is having tachypnea, and I put in the scenario oxygen mask beside him. This station I am testing you in ATLS scheme. Okay? So let us have a station related to ATLS that can come in the exam. Okay? Any volunteer that want to take this station?
I can
Yes,
try.
Sorry, doctor, please, but one question,
Yes.
please. Pulmonary embolism is a CRISP or Atlas protocol?
Pulmonary
I
emboli.
know, I know
Yes,
it's a CRISP protocol.
is a CRISP, yes, CRISP protocol,
Yeah,
which
okay,
goes
doctor.
through A,
Thank
B,
you.
C, D, E. Advanced trauma life
Yes,
support when you get trauma to the patient.
trauma or burn.
You are the
Yes,
trauma
yes,
team
doctor.
leader
Okay.
in the ED.
Yeah.
Paramedics wheel in a 45-year-old male, John. Paramedic handover. This is John, 45. He fell approximately 3 meters from scaffolding onto concrete. GCS was 7 E1 V2 M4 at the scene and has remained static. His left pupil is 6 millimeters fixed and dilated. Right is 3 millimeters and reactive. He has an oropharyngeal airway in situ and is on a non-rebreather mask. We've immobilized the C-spine with blocks and tape. No obvious external bleeding, but there is a large boggy hematoma on the left temporoparietal region. The nursing staff looks to you for instruction.
This is one of the scenario of ATLS course to treat you about such a case. And how this case can come in the exam, this case can come in the exam by giving you a file of this patient, and then you have to speak to the consultant, neurological consultant on call. Because you must know this patient who have hematoma need urgent CT scan and maybe urgent craniotomy for large subdural hematoma. Okay? So these type of station can come to the exam, which is a head injury with low Glasgow Coma scale. Okay? So anyone want to volunteer to take this station?
I can try this one.
Very good, very good. You always benefit from trying. So if you have this kind of patient with very low Glasgow Coma scale head injury and his spine is already been fixed, so what is your management? What you will do?
I will call the patient to see if patient is arousable or not. And then I will ask the nurse to prepare for airway management. I want to do definitive airway management with a ET tube of a proper size. Adult male, size 7, ET tube should suffice. In the meantime, I will ask my trauma team to secure 2 large bore IV channels while we are getting the airway secured. I noticed that the heart rate is quite high, 105 tachycardia, respiratory rate is also high. Then after airway secure breathing, I will check for bilateral chest movement, if it is equal on both the sides or not. And if there's any signs of pneumothorax with percussion auscultation, I will confirm that after large bore,
Yeah,
two
that's
large bore
fine.
chambers.
Okay, let us take it little by little. You will go to ABCDE scheme. Is that right?
Yes, correct.
Okay. So we'll go to ABCD scheme, the nurse. But what is really worrying in this sign that pupil is unequal. So maybe he
And
started for lateralization, start to lateralize.
lateralization signs. Yes.
Yeah. Okay. So let us hear the you approach the patient.
Primary survey.
You begin primary survey. You done that correctly. Airway. It checks C-spine. Manual. Inline stabilization correctly maintained. And OPA is in situ. But you hear a snoring sound. Note some pulling secretion in the oropharynx. Patient is not gargling on the airway. So what do you do?
I will do suctioning and
Yes, excellent. We'll do suction. Okay, confirm. This is important because this is number one for the airway, which is vital. So here I've done your answer. You will do suction. That is very good. And you know what is urgent in this patient? Is urgent CT scan once he is stable.
Yes.
If you mention CT scan while patient unstable, this is completely wrong. So you perform rigid suction under direct vision, cleaning the blood, saliva from oropharynx. The snoring sound improve transiently, and airway remain precarious. He does not tolerate suction well. He has no gagging reflex. Anesthesis. You mentioned that you will prepare for endotracheal intubation size 7.
Yes.
You shouldn't do that. Anesthetist should do that. So
okay.
I will call the anesthetist to put endotracheal intubation. Okay? Because one of the team is anesthetist. So anesthetist, I am here. This patient is Glasgow coma scale of 7. Threatened airway. Do you want to proceed with definitive airway, which is endotracheal tube? What do you say?
Yes, definitely.
Yes, very good. And to confirm. So you done yes. Now we're still unable to do CT scan, and we're still unable to call neurologist to prepare for terrifying operation after large subdural. We still don't have a stable patient. And here is the monitoring of the patient, and here is the reply. Okay. The reply was the anesthetist performed rapid sequence induction, RSI, size 8 cuffed endotracheal tube, positioned to confirm it by capnography that it is in place, equal bilateral chest expansion. Patient is now ventilated with the airway secure, breathing control, saturation raised to 99. You can see saturation was below when we started the scheme. Yeah, now it is saturation improved. It is heart rate is 90, blood pressure 160, radial pulse is strong, capillary fill 2 seconds, pelvis is stable, gentle. Nurse, blood pressure is trending up, doctor. Heart rate is dropping slightly. Okay, so you are at D, which is disability. The anesthetist remind you that the patient is now sedated and paralyzed, prior to intubation, Glasgow Coma Scale 7, fixed dilated left pupil. What do you do?
I would ask to get a
Yeah.
CT scalp brain stat.
Yeah.
Because hemodynamics seems stable, but I think he's going into Cushing's. So I
Yes.
need a CT first.
Yes, CT scan, and we need to contact a neurosurgeon
Radiologist.
right away.
Yes.
And when you speak to the neurosurgeon, you will say what you want to do.
Mm.
You would say, I have a patient who is having deterioration low Glasgow Coma scale of 7.
Mm.
Here is the examiner analysis. This was toe and die of rapid deterioration head injury scenario. Airway, correct intubation, rapid sequence intubation called RSI. Glasgow Coma scale of 7 and the airway threats and breathing maintain a normocapnia, which means that the endotracheal tube is in the correct place to avoid vasodilation, vasoconstriction, circulation, noting blood pressure is 160, heart rate is dropping. 90 suggests Cushing response, which is raised intracranial tension. Cushing response. Disability, critical step in recognized fixed pupil, crushing reflex due to herniation. So he's herniating. Immediate action is required. Elevate the head 30 degree. If the spine, what do you say?
Hypertonic saline and head elevate.
Yeah.
And
Exact.
mannitol.
Administer hypertonic saline or mannitol. Urgent CT scan. Code red. You must know. Do you know code red and code blue?
Yes.
What is code red? What is code blue?
Code blue is apnea.
Yeah.
ايوه
جبت لك هدومك من على الحبل خدتها.
There is someone
لا
which is opening his mic. So yes. Okay.
Code red
Continue.
is major hemorrhage. Code blue is apnea, non-responsive. Code red is major hemorrhage.
Excellent. Very good. So this is code red, urgent neurosurgeon referral for potential craniotomy bare hole. Exposed injury to the patient, and nowadays they do total body CT scan. So to pass this station, you must verbalize your finding when the blood pressure 160, dropping in heart rate. I am concerned about raised intracranial tension explicitly. So this is one of the station in the protocol with ATLS course, and you done very good. For me, I will give you a good pass. Okay?
Thank you.
Very good. Let us get training, because again, one of the stations that is important is CRISP. CRISP protocol. And CRISP protocol can happen in multiple scenarios. One of the commonest is intestinal anastomosis dehiscence, post-operative. For patients who have done a Hartmann procedure 1 week ago, now he is ill. Any volunteers that want to take this station?
Yes, sir, I can go for it.
Very good. I like this. Don't worry, you're not in the exam, but you are training to pass the exam, to exquisitely perform the exam very well. Very good. So let us take this station. And here is septic surgical patient. Okay? Common station that come. I've heard a lot of very wrong things. I will stop the time. Someone told me that if the patient complains of severe abdominal pain, I will apply CRISP protocol. If it is mild abdominal pain, it is appendicitis. This is completely wrong. Okay? So the name of the doctor, what is the name of the doctor taking the station?
My name is Fahd.
Fahd. Very good, Fahd. I like the courage. Let us see the station. I will read the scenario to you. Welcome to this crisp simulation. You are faced with deteriorating post-operative patient shows classic sign systemic inflammatory response syndrome and the potential organ dysfunction. In your response, I'm looking for a structured ABCD assessment. Okay, so here is the scenario. A nurse.
Doctor, I'm
Yeah.
calling from Ward 4. I'm worried about Mr. Arthur Miller, a 68-year-old gentleman who is day 2 post-emergency laparotomy for a perforated sigmoid diverticulum. He's become increasingly agitated over the last hour. He's shivering, and his urine output has dropped to less than 10 milliliters in the last 2 hours. I've just taken a full set of observations, and his NEWS 2 score has jumped. Now, examiner feedback. Welcome to this CCRISP simulation. You are faced with a deteriorating post-operative patient showing classic signs of systemic inflammatory response and potential organ dysfunction. In your response, I am looking for a structured ABCDE assessment. Remember, in a septic surgical patient, the RR is often the earliest indicator of physiological distress. Ensure you are thinking about the sepsis 6 bundle alongside your primary survey. Your tone should be calm and your commands to the nursing staff clear. Proceed with your assessment.
Okay, so Dr. Fahd, what would you do?
I will manage this patient according to CRISP protocol.
Excellent.
Assessing airway of the patient, and if the patient is talking, then airway is clear. Assessing breathing of the patient and oxygen saturation. So SpO2 is 93.
Do you know what is sepsis 6?
Yes, sepsis 6 bundle, giving 3 and taking 3, yes.
Excellent, excellent, very good. So I will say this on your behalf. I will start ABCD protocol.
Yes.
And do sepsis 6 bundle. Okay. Now here you will have this reply to the nurse. You got the monitor that goes with the station. You can see he's tachycardic, he's hypotensive, and saturation is dropping.
Yes.
Okay. So let us hear what the nurse will say to you.
Okay.
Okay. Now the nurse will say, okay, doctor, I have emergency trolley. Mr. Miller is very restless and he's shivering, getting worse. He's trying to pull his gown off and his breathing looks very labored now. I have got a non-rebreathing mask. You must know all different type of mask and each mask when to use it. Okay? And a bag of Hartmann ready. How much oxygen should I start him? And how much fluid do you want me to give him? This is an important question to you, Fahd.
I will give him 1 liter of normal saline over 1 hour.
Okay. What about oxygen?
Okay, doctor. I have the emergency trolley here. Mr. Miller is very restless and his shivering is getting worse. Okay, doctor. He's trying to...
I'm sorry about this, Dr. Fahd, but it's because when I get it into Zoom, he get too many voices instruction. But you're doing well, okay? And here we'll go to this stage. You pass this stage. We'll say we'll do A, B, C, D, E. Okay, and then send. And then you go to the next stage. And you said how much oxygen would you give him?
7 liters per minute rate.
Why not 12 or 15 liters per minute? He's hypoxic.
Actually, I'm
and you're not worried about hyperoxygenation.
I'm not sure of that.
Yeah, I think the ideal answer is
Doctor, I'm glad you're here. I'm calling about Mr. Arthur Jenkins in bed 4. He is 68 years old and date 3 post-op following a laparoscopic anterior resection for rectal cancer. He was doing well yesterday, but over the last hour, he has become increasingly agitated and confused. He's shivering quite violently, and his urine output has dropped to less than 10 milliliters in the last 2 hours. I'm really worried he might be developing a leak or sepsis. What would you like to do
Mr.
first?
Jenkins is very restless and keeps
Now
trying
examiner
to sit up,
feedback.
saying he doesn't feel
Welcome
right.
to this
His breathing
CCRSP
sounds
scenario,
shallow and
doctor.
fast.
You are
I've
faced
managed
with
to
a
get a
common but
20-gauge cannula in
high-stakes
his left
surgical
arm,
emergency.
but it was
A
difficult
news
because
Okay, we'll continue this scenario. So you give oxygen, 15 liters per minute, and you give fluids. Okay. And what do you do after that? What's your next step?
Assessing
Do you
of
transfer the
circulation.
patient to high dependency unit or not?
I'll assess the catheter and renal function if there is
Renal
suspected
function
renal
is
impact.
impaired.
Yes, if renal function is impaired, so I will transfer the patient to a higher care.
Yeah. And the higher care, what you request from higher care? You got oxygen, you got fluids, but we done A, B, airway, breathing. Have you done C, D, and E?
Assessment of circulation.
Doctor, I'm glad you're here.
and
I'm
the
looking
response
after
of-
Mr.
and the
Arthur
response of the
Jenkins in
patient
bed
to
4.
fluid.
He's 68 years old and is day 3 post-op following an
I will
anterior
stop
resection
this.
for rectal cancer. Over the last hour, he's become increasingly agitated and confused. He's shivering, and his urine output has dropped significantly over the last 4 hours. I've just triggered a News 2 of 8. Can you come and see him immediately?
I will add to
Now,
this program
examiner
post
feedback.
the voice.
Welcome to the
Very sorry about
CCRIS
this.
scenario, doctor.
Okay.
You are
So-
faced with a deteriorating
Well,
post-operative
it's all
patient
right.
who is demonstrating clear signs of
Okay.
systemic.
So after that, you will transfer him to high dependency unit. But have you looked into his abdomen? Because he had an operation 2 days ago. So what do you do, Dr. Fahd?
I will complete my survey,
Yes.
assessment of circulation, and the response of the patient to the fluid bolus.
Yes.
Assessment of Glasgow Coma score of the patient. This is disability, and exposing the patient to see the site of the operation and the drains.
Okay, you
and the
found the site of the
colostomy.
operation. There was oozing of fluid from the wound. Serosanguinous fluid. What do you do?
I will fully examine the patient after stabilizing him.
Yes.
I will do full abdominal examination.
Yes.
I will ask for labs and imaging.
Excellent. Very good.
Okay.
Yeah. So I think you done very good answer, and you done very good in this station. How this station can come? It can come. We get an actor, and the actor have a dressing on his abdomen. Don't expose the dressing, and he has oxygen mask beside him, and he look to be tachypnic. And we get you Muse chart.
Doctor, I'm Nurse Sarah from the surgical ward. I'm calling about Mr. Arthur Jenkins, a 60.
And we get you Muse chart. Do you know what is Muse chart?
Muse chart?
Muse, yes, MEWS. Minimal Early Warning Chart. Do you know that?
Okay. No, this is the first time.
No, you have to read it. How can I tell you in an OSCE station that this is critically ill or he is a normal patient? The answer is the Muse chart. Yes, you can answer, Dr. Fahd.
I know that the answer is assessing of the vitals of the patient.
Yes, very good. And you know the
If the
vital
patient-
signs in the NHS is recorded by what is called Muse chart. And you get a score,
Okay, sir.
which is called Minimal Early Warning Charts. And this, it has a score. If the score is above 6, he has to be transferred quickly to ICU or high dependency unit.
Okay.
Okay. And if the Muse chart is, let us say, 2 to 3, then you need more frequent observation. So you must go to the internet, mute chart, muse, and then get used to it, because we will get a chart to you that this patient is blood pressure 100/60, his pulse is 130, his temperature 38. This is when you know that you have a crisp case, crisp protocol to
Okay.
apply. Okay?
Okay, sir.
Okay.
Okay, sir.
Okay, very good. But you done very well, Dr. Fahd. So,
Thank you, sir.
let us take, do you want to take another station, post-operative deterioration? Or any volunteer?
Of course, if
Of
there is no
course.
volunteer, I can take it.
Yes, very good.
I want
Okay.
to.
Here
Okay.
is the station, and we'll listen to the scenario. Heart rate 75, blood pressure normal, and here is the scenario. It will be read shortly, and you tell me what you need to do. Welcome to assessment. Doctor, you are faced with a high acutely surgical patient. A news score of 7.
Doctor, I'm glad you're here. I'm the staff nurse looking after Mr. Arthur Jenkins in bed 4. He is a 72-year-old gentleman, day 2 post-laparoscopic anterior resection for rectal cancer. He was doing well this morning, but over the last hour he's become increasingly restless and is complaining of vague abdominal pain and shortness of breath. His urine output has also dropped significantly. He's only produced 15 ml in the last 2 hours. Now, examine our feedback. Welcome to the assessment, doctor. You are faced with a high acuity surgical patient. A NEWS 2 score of 7 triggers an urgent clinical response. In CCRISP, we emphasize the structured ABCDE approach to ensure no life-threatening issues are missed. As you begin, consider the surgical day 2 context. Common complications include basal atelectasis, pneumonia, pulmonary embolism, or the early signs of an anastomotic leak. Ensure your first steps involve a rapid primary survey and immediate life-saving interventions. Be prepared to communicate your findings using the SBAR tool if you need to escalate to the consultant.
Do you know what is SBAR tool, Dr. Fahd?
Spark tool?
SBAR tool. SBAR.
No, sir.
Very important. Go to SBAR tool, which is a tool in communication skills. S for situation, B for background, A for assessment, R for recommendation. So when you speak to the consultant about this case, you apply SBAR tool. You tell him, this is the situation. And this is the background situation. Patient having severe abdominal pain and hypotensive. Background, he had operation, laparoscopic anterior section 2 days ago. Then assessment, I think a patient have severe abdominal sepsis and might need to have reoperation, or he might have a dead bowel. And the arrangement of your advice as a protocol. So you must know SBAR protocol. Okay, Dr. Fahd? Okay.
Okay, sir.
So,
Thank you.
so we'll apply here, apply ABCD approach, send. And you can say this was voice, but anyway, we'll apply ABCD to this patient. So you check airway, you check breathing, too large cannula, and this is what the nurse will say to you after ABCD. Yes, doctor, I have got the emergency trolley here. Mr. Jenkins is still restless. He can speak in short sentence, but he seems to be working hard to breathe. So there is problem with breathing. I have cleared some space around the bed for you to work. And this is the blood pressure and pulse. Notice his oxygen saturation is 92, dropping, temperature 38. What is your specific action for A and B to this patient? What you will do, Dr. Fahd?
Airway is, I will check if the patient is talking. So
Yes.
airway is clear if the patient is talking.
Yes. Breathing.
breathing. I will assess breathing by assessing
Yes, doctor.
the respiratory
I've got
rate
the
and
emergency
the
trolley
oxygen
here.
saturation.
Mr. Jenkins is still
Yes.
restless. He can speak in short sentences, but seems to be working hard to breathe.
He
I've
can
cleared
speak,
some space around
so
the bed for
airway
you
is
to
okay.
work.
So what you should
Now,
do is
examiner
listen
feedback.
to
A good
his
start by
chest
identifying the correct framework. However, in a high-pressure
for B.
CCRISP or MRCS scenario, you must verbalize and execute the actions rather than just naming the approach. With a NEWS 2 of 8 and a saturations of 92.
Patient deteriorating, you should think of CRISP protocol, treat as you find. So airway is fine because patient is speaking. And
Yes.
breathing, you should, I would say, do auscultation to his chest. This is what you should do. And here you notice the monitor was still patient is hypoxic. So you need to give him fluids and need to apply sepsis 6 protocol or sepsis 6 bundle.
Yes, sir,
And
for
here you
circulation.
get the reply. I've got the stethoscope for you, doctor. As you listen, reduce air entry in both bases and some coarse crackles. He's struggling and he's quite pale. I have placed him on 15-liter oxygen. You remember the protocol in CRISP, I
Yes.
think is 15 liters. Okay? With non-breath mask,
Yes.
non-rebreathe mask, as per emergency protocol. Saturation have picked up slightly, but this patient, what is the next step you will do?
1 liter bolus of normal saline.
Very good. But what about his breathing? He did respond well to oxygenation, but do you think he need to be intubated or not?
At the current stage, no need for intubation as the patient is responding to mask of oxygen.
Okay. Let us hear the examiner feedback. You correctly identified to listen to the chest. That is correct. You must have assertive systemic priority of intervention. Oxygen saturation 92. His NEWS score of 8. A very first word out of your mouth should be start 15-liter high flow oxygen via non-rebreathe mask. So please remember this sentence. Start 15-liter high flow oxygen via non-rebreathe mask. Don't wait
Okay.
and listen chest before starting assessment for hypoxia. Systematic B, assess the breathing, listen to the chest. Remember, look, listen, feel, and shock. Until proven otherwise, this is day 2, patient is shocked, in shock. Sepsis, hypovolemia, query hemorrhage, and thromboembolism, PE, also is a possibility, while 2 days is a little bit early for that. So this is another scenario that you get used, but very good performance. Congratulations,
Thank you.
well done.
Thank you.
So,
Thank you.
okay. Now, I will show you something else which I think to help you to pass the exam. All of you, I think, will go to the exam, most of you in February. Is that right?
Yes, sir.
Yes. Some in April, like Dr. Amira, but most of you in February. So now, by the use of machine learning, I will tell you what station you need to concentrate at. It is OSCE prediction module. Okay. So please bring pen and paper. These stations, according to machine learning, are common stations to come in February. So please prepare this station well. Number 1, because the Royal College is listening to our broadcast, so no one knows the exam. No one. The exam is very confidential, controlled by ICBSE, excellent organization. Even we as an examiner, we don't know the exam. we know which station we will examine only the day of the exam, where by that time you all are in your OSCE station to be examined. Okay? But I've took my artificial intelligence, VASAI, I told them, go to last 10 years of the last 10 years of the Royal College exam and see which station comes frequent and which station comes less frequent. And if I ask you to give me what station will come, what is your prediction? This is just computer prediction called machine learning. Okay? So here I put the exam, any month I like, February 2026. Everyone is happy with that?
Yes.
Okay. So we run prediction. Give me prediction. What 17 station will come in this exam? Now he will go, and can you imagine? He will look into the last 10 years. Which station come? Which station vanish? Which station doesn't come anymore? Which station like to be given by Edinburgh exam in February? All this by what is called machine learning. And now it is looking over a huge amount of files to see what he predict these 17 stations to be. So bring your pen, bring your paper, and I will give you some of these predicted stations to concentrate at. Okay? Prediction 17 station. Here it is. Number 1, breaking bad news, colorectal cancer. And this is the confidence ratio of this prediction. So you can see he predicted this station, 75% it will come. But this one is 95%. So please, you all are like my sons and daughters, and I wish you all to pass first shot. So please read about breaking bad news and the spikes system. Read about spike system for breaking bad news colorectal cancer and consent for laparoscopic cholecystectomy. How to take consent. You need to mention some detail about the operation, some complication, not all complication, and so on. Lower limb vascular examination. Please, you can have chronic ischemia and how to do Doppler assessment. And you can have varicose vein. After that, brachial plexus shoulder anatomy. He predicts this station will come 85%. Okay?
Okay.
Phone call referral is bar system. So please, all candidates, the 42 that hear me now, please read about SBAR system, situation, background, assessment, re-evaluation, or recommendation. This is important when you speak to a consultant or colleague and so on. And this is have confidence of 75% confidence that it will come as a station 5. So please, all of you, and mention here that there is emergency trend toward this frequently station 5. It reflected updated curriculum. Some station becomes important because we have a problem when junior staff speak to a consultant. You must be precise, accurate, know exactly what to do. Okay? Now, mock exam training, now it also create for you. So these are the common 5 stations that he predicted will come. Okay? It will not predict the whole 17 station, but it can give you a mock exercise that it will give you 17 station. They think that it will help you to to pass this exam, what I call mock exam training. Okay? So, and here also wild card station is a station that might be wild card that will come. So prepare for them. He put me 3. Read about pediatric intussusception, history and communication. Okay? Strategic outlier detected. So please read about pediatric intussusception. How do you manage? How to diagnose? Bladder scan? What do you say to his mother, and so on? Critical care, burn fluid resuscitation, Parkland formula. This is very important. Come into a lot of exam. Okay? And the third station, operative skill, tendon repair simulation. Commonly we give you knot, suture tying, excision of nevus. All of them really operative skills are really very simple and easy for you to pass. So let me finish by opening the floor for you if you have any question. I will stop sharing here. I will
Dr.
stop sharing.
Farouk, I just
Yes.
need to tell him, you know that we modified the Parker's formula. In the past, the Parker's formula for hundreds of years is the 4 times the body surface area times the burned area. So now, according to the new regulation, it's become 2 instead of 4. Just to the student to know that.
Excellent.
Is
Very good. So
anyone have an idea about the change of Parker's formula or not?
Yes, Dr. Sheen, it changed from ATLS 9C.
All right. Okay. So just to know that it is changed. Just to become 2 instead of 4 in the equation.
And I think we should give it all in 16 hours, not in 24 hours. Like in the start, we were giving first half on the first 8 hours and the rest within 16 hours. Nowadays, it's all in 16 hours.
I've just seen your chats now. I'm sorry I couldn't reply in your chat with the amount of software I'm dealing with. So I'm sorry, but Professor Shireen have replied to most of your question. There is a question here, when to do MMSE? Do you like to reply, Professor Shireen? When do you do MMSE?
You can reply, Prof.
Okay. So MMSE, when it come in a station, it is written in the candidate instruction. Please calculate MMSE. So we don't let you decide which score to do. There is another station for cranial nerve. We tell you calculate AMTS score. So don't worry. We will not leave you without knowing what is your task. We actually tell you the task multiple times. For example, in abdominal examination, examine this patient abdomen within 6 minutes, and we repeat at the end, this is not history taking station. Please restrict your communication to only abdominal examination. Any other question? I can see in the chat. Can you show us prediction of April exam? Yes, I can. I will show it to you quickly. No problem. Okay, so I will share.
Dr. Muhammad, another question.
Yes,
Another question
please.
regarding MMSE. If the task were to ask to do MMSE frankly, and I
Yes.
started to test the patient about
Yes.
MMSE question, shall I continue questioning the patient if the patient shows severe or low dementia from first few questions? I mean, if I asked him about 10 questions and the patient now in severe dementia, shall I continue questioning him about the items of MMSE, or shall I continue with the rest of history by asking family history and social history and medical history and all
You should
these?
do both. You should do both. You should do MMSE and continue the history for the cranial nerve examination. You should do both because they are in the candidate instructions.
Yes,
Okay,
yes, I
so
understand.
you get used to MMSE to do it quickly within 2 minutes, and we don't bring you an actor who is completely delirium. This situation never happened. What we tell the actor is answer one question right and another question wrong. So here, as you can see, I can predict April exam 2026. Let us predict the 17th station. Now it will go backward over 10 years back, and it will tell you the commonest prediction or the commonest 5 stations that will come. This for the candidate like Amira, which I I know she will pass her exam. She studied very well and she's doing very well with her training with artificial intelligence. Her score is rising rapidly, and I'm sure she will pass.
الله
And
يشكرك إن شاء الله أسمع منك.
no,
تسلم.
you're welcome. You're welcome. You're doing
مع
very good
السلامة.
work. Very good work. Excellent. Now here is prediction. You can see it is take a lot of time. You can imagine going into 10 years back. Now here is a prediction. This is for April, not for February. April, commonest station. Bringing bad news, its frequency, it comes 15 times from October 2024. He has confidence, 95% it will come. Anatomy, inguinal region and hernia, 90% accuracy. Okay? Critical care, post-operative oliguria, acute kidney injury. Okay? 85% accurate. Okay? Then skills excision of cutaneous lesion, 88% it will come. And the last prediction is communication angry relative of cancer surgery. Please remember spike system, speak slowly, speak professionally about the cancellation, and you apologize to the patient, and we're going to put you on the next available list. I understand your position. I'm really very sorry for this, and hopefully we try to get you as soon as we possibly can. Unfortunately, there was an emergency, but I understand your feeling. I'm very sorry for that. I apologize for that. Don't answer him that you should complain. You should complain to the hospital manager. I am sorry. This is wrong for you, or things like that. So please prepare yourself. And I already made a quick scenario what you should do in communication skills angry relative. If you go to my tube station, search for angry relative in my MRCS course, you will find a lot of benefit. And I hope I have answered your question. And actually here, it can even predict. This is April exam in Egypt. I can add even April exam in London. I can select the country that has the exam, and it will give you a training for you to get the most frequent 17 station and arrange your performance. All this done by machine learning. I will stop here. Okay.
Prof, I think some put a question about the AI and how they can join this AI. If you can give him
Yes.
the idea how they can join this AI. Okay.
This artificial intelligence is not free with charge, because every time I ask AI to do something, he deal with what is called the token. Now I can see I have spent 2 million token today just by this webinar. What is token? Token is the currency that we use artificial intelligence. So this is not a free with charge AI. It is a paid program. If you go to YouTube channel called the Vascular Online Training, and you join as a member in the level of courses, because I have 7 levels of members. Member at courses, which goes something like $2 per month. I actually pay for each candidate $10 for this course to happen. So I pay a lot more than they do, but I cannot give it free of charge because the YouTube prevented this. So if you join YouTube at courses level, this will open to you all the training module that I have created. ATLS training module, history taking trainer, communication skills trainer, surgical anatomy trainer, surgical pathology trainer. All of them will be open to you, plus prediction of which station will come to the exam. So I'm sorry we took a long time of you. We're now
Sir, what is the name of your YouTube channel, please?
It's
What is
called
the name of your
Vascular,
YouTube channel?
Vascular Online Training.
Okay, sir. Thank you.
Vascular on YouTube. You will have a click join member, and you can ask Dr. Amira. She's very active member, and all these courses that train you well. I have never seen someone who have such a course and did not pass. It did not happen because it prepare you well and give you assessment well and raise your level quite high. Actually, I was surprised. One of my candidate, he passed MRCS last week, and he did give me his score, and it was exactly the score he got from my AI trainer. He got 171 score, and this is actually score he got in the knowledge and in the skills. 171. He was very good chap. He was from England, but I was amazed how accurate my program is. So here it is, and I wish you all pass the exam. Any question? I can see we have around 41 candidates. Any questions you like to fire in the last 5 minutes?
Thank you very much, sir.
You're welcome. I wish you all the best. I hope all the 41 will pass the exam and will tell them congratulations, well done. You will have a great career in surgery. And finally, I would like to thank very much Professor
Yes, sir.
Shireen Al-Hariri for
Thank you.
coming and
Please,
replying
sir.
to this questions. Thank you very much, Professor Shireen.
Okay,
And
thank
thank
you.
you very much, my dearest, you're welcome. And thank you very much, my dearest Dr. Muhammad Mahmoud, who arranged this link from his account on Zoom. And this is the reason we were able to have unlimited time to go up to 2 hours. So thank you very much, Dr. Muhammad Mahmoud, for this. And I see you next time. And be on the Telegram. If you have any problem, any question, we like to help you. Thank you very much.
Sir.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa rahmatullah, sir.
Alaikum assalam.